So my name is Caterina Mosti. I'm a neuropsychologist and sleep psychologist. And today I wanted to kind of talk a little bit about sleep disturbance and Parkinson's disease, and we'll talk about kind of underlying mechanisms and treatment and that kind of thing. A little bit about me. I'm primarily a neuropsychologist, so I'm currently in our UCSF Fresno Alzheimer's and Memory Center. And I specialize really in kind of assessing and diagnosing neurodegenerative disorders, but really kind of see a whole host of neurologic diseases. Concurrently, I always kind of did a little bit of training in behavioral sleep medicine. And so currently I have a once weekly clinic where I just do behavioral sleep medicine interventions and specifically cognitive behavioral therapy for insomnia, which is a mouthful. So we always say CBTI. I say for this presentation, if you guys have any questions, by all means, feel free to ask them along the way as opposed to waiting to the end. I really encourage that. I think it's probably REM behavior disorder. Does that sound right? So I'll try to remember some things to talk about for RBD as well. Anybody else before we move on here? Okay, I'll keep it moving. So really the goals today are kind of identify underlying mechanisms for sleep disturbance. So what I mean by that is kind of what things kind of contribute to sleep disturbance or sleep changes as we age normally, and what things, particularly from Parkinson's disease, seem to be contributors. Understand the types of sleep disturbances in Parkinson's disease, which can really be quite varied and actually can change over time. And at the end, I want to talk about treatments and kind of at-home interventions for kind of all these different sleep disturbances. So briefly here, when we talk about underlying mechanisms, I want to talk about kind of what is normal sleep and kind of sleep changes as we age, absent of anything like Parkinson's disease. So increasing age is kind of a risk for developing sleep disorders in general. So as we age, sleep naturally becomes a little bit more fragmented. And you guys probably maybe notice as we age that waking up to go use the bathroom becomes a little bit more frequent. Maybe harder time actually staying asleep throughout the night becomes a little bit more frequent. And actually, as we age, we all need a little bit less sleep over time. So we all kind of hear this magic 8 hours. That actually can change a little bit as we age. So it's a little bit closer to 7 hours as we get into our 60s and 70s and so on. The question is Parkinson's disease kind of contributing to some of these sleep disturbances, or are kind of these sleep disturbances causing worsening Parkinson's symptoms? We actually think it's probably a little bit bidirectional, but know that, again, increasing age is just a risk for some of these changes to be happening on their own, absent of Parkinson's. Hopefully you guys can see this on your screens. Maybe I can move my things over here. So just talking about kind of the pathology a little bit, you guys, I'm sure, are kind of familiar with what happens in Parkinson's disease, but Parkinson's actually really targets sleep in particular, and we see a lot of sleep changes because there's disruption of a lot of different neurotransmitter systems that we need to work smoothly for good sleep. And so we talk about dopamine quite a bit, and dopamine's really kind of important for controlling two different sleep systems we have. So all of us have an on-off switch for sleep, which basically means you wake up feeling refreshed, and then over the course of the day, we feel a little bit more tired. That's kind of your on-off switch. And then we have your circadian rhythm, which is your 24-hour clock. So what I mean by that is most people know if they're like a morning person or a night owl, that usually stays the same whether or not you had a good night's sleep. So there's kind of actually multiple systems going on in your sleep. So when we talk about disrupted sleep, we always try to kind of pick apart, well, what do we think is a little bit of a change here? And when we have disruption in the dopamine system, you can actually have all these systems affected, which it makes it tricky. I think to answer your question about maybe REM behavior disorder actually ends up happening as well because some of the Parkinson's pathology or the Lewy bodies actually park themselves right about here in the brainstem, which is another kind of sleep center. And so when you have disruption of the sleep centers right here in the brainstem, it actually suppresses the hormone in your body that keeps you almost paralyzed during your dreams. Okay? So normally when we all dream and we're in REM stage of sleep, we're actually all paralyzed. We can't move our muscles. But sometimes the Parkinson's pathology actually moves from the midbrain here into the brain stem, where you can actually see some movement in sleep, which is a little bit unusual. And so that's why you can have some movement in sleep. with Parkinson's. Okay. We talk about dopamine as the big thing that changes with Parkinson's, but there's actually many other neurotransmitter systems that get affected: acetylcholine, serotonin. So you kind of have to think that there's a lot of different hormones that are suddenly out of balance, and so as a result, you can kind of see a lot of different sleep changes. I always say Parkinson's is actually pretty tricky when we talk about the sleep changes that we see, in that they can be so varied. So really, we have insomnia, we have sleep apnea, we have REM behavior disorder, we have all these things that can happen. And that's partially because Parkinson's is a little bit unique in that the pathology parks itself in different parts of the brain for people. And it's not kind of a one size fits all. So some people have, just kind of pathology here in the midbrain, which you would just see primarily motor symptoms. But some people have it more in the brainstem. Some people have it more in the cortex. And so it's a little bit of a mixed picture for everybody, which, as a result, can have these really wide variety of sleep symptoms. So it's kind of hard to pinpoint where these things are going on. Okay. Let me move you back over here. So, we talk about Parkinson's as kind of being a precipitating factor, and age being a precipitating factor for some sleep changes to happen. But as a result, often, I think, neurodegenerative disease or not, we all end up doing a lot of factors that kind of perpetuate the sleep issues. So oftentimes, if you're sleeping poorly, people as a result kind of sleep in. They may feel really tired, so they're going to bed earlier, and then all of a sudden waking up in the middle of the night a little bit too early. Sometimes people spend more time in bed. So you have to think, if you're getting poor sleep, oftentimes people kind of say, well, maybe I'll just kind of sneak into bed a little bit early, see if I can catch a couple hours here, a couple hours there. And as a result, you kind of get this really disrupted sleep. The other thing we talk about is oftentimes people, understandably so, are kind of looking for any fix for poor sleep. And so we often see kind of these over-the-counter sleep medications that people take, which actually I'll talk about which ones are good to take and which ones are not so good. Because actually some of these sleep medications can cause some cognitive side effects that we want to make sure that we're not kind of exacerbating anything. As a result, people often take caffeine or kind of try to keep themselves up if they're having poor sleep, which again can kind of disrupt things. There's some new research saying that caffeine can have a half-life of up to 20 hours in certain people. And so I say, caffeine before lunchtime is okay, but anything after that can really actually disrupt your sleep, even if it doesn't feel like you're necessarily wired. The other thing that can maybe kind of perpetuate some of our bad sleep is what I say hypervigilance to poor sleep. And so you kind of have to think, if you've ever had a bad night of sleep and you're laying there in bed, you're kind of acutely aware of the fact that you're not sleeping. And that sometimes can generate a little bit of anxiety. You start tossing and turning. If you're having any motor symptoms, then you're super cognizant of this. That can cause anxiety. So it's kind of like this never-ending cycle. So when we kind of intervene for some of these sleep issues, we kind of want to break the cycle for all these different factors that on their surface seem like would be really helpful for managing sleep, but can actually perpetuate the sleep issues. All right, so I wanted to just kind of cover the types of sleep disturbance that we treat. And oftentimes it's hard for us to know in the beginning kind of what we're looking at. So we often hear people say, I just can't sleep. My sleep is horrible. I can't get a good night's rest, which is, of course, good for us to know. But we need to kind of pick apart what exactly we think is going on so we can kind of have the right intervention. I say approximately 2/3 of people with Parkinson's disease have some form of sleep disorder, and that can, again, change over the course of illness. So people with Parkinson's have an increased risk of sleep apnea, which is, because of either throat size or tongue size, not getting enough oxygen while you're sleeping. And so actually the blood that's going to your brain, it has a lower oxygen saturation content. Insomnia, or kind of other insomnia symptoms that are secondary to a mood disorder. For example, anxiety or depression causing insomnia is quite common. Circadian rhythm disorders, which are actually a shifting of your 24-hour clock. An example would be, let's say for most of your life, you went to bed at 11, you woke up at 6. all of a sudden you're going to bed at like 8 p.m. and you're waking up at 4 a.m. Or on the flip side, all of a sudden going to bed at 2 a.m. and waking up at 10 a.m., kind of like your 24-hour clock shifting a little bit. REM behavior disorder, which we've talked about before, which again is kind of changes to the sleep cycle that cause movement during specifically REM sleep, which tends to be that type of dreaming that's very emotionally charged, which is why people often describe it as very vivid, a lot of movement during sleep, and of course, restless legs. Okay, so this is just a chart for us to kind of view all the things we look at from a clinical side. And so, with Parkinson's, we always want to kind of consider these extra factors when we're treating sleep issues on top of kind of regular aging. So we want to talk about neuropsychiatric symptoms, for example, hallucinations that can be a result of the medication you're on, different medications that can cause some sleep issues, the motor symptoms, how they may contribute to poor sleep, autonomic dysfunction, which means having to get up to use the bathroom a little bit more frequently. And again, these other kind of things that we talked about before, your 24-hour clock and your on-off switch for sleep. Okay, so this is where I want to spend kind of the bulk of my time is, well, how do we actually treat these sleep disorders in Parkinson's disease? And it's really going to depend on kind of what we're treating. So as we talked about before, again, the sleep issues can really vary quite a bit. And so I'm going to focus more on kind of fragmented sleep and insomnia, but I'm happy to kind of fill in some other things as people have questions, and we can maybe spend a little bit more time there. Okay. So for the past 5 years or so, the American Academy of Sleep Medicine has actually recommended behavioral sleep medicine interventions instead of medications for the treatment of insomnia and circadian rhythm disorders. And what that means is people have often, anytime they have any sleep issues, have been put on Ambien or trazodone or kind of these other medications anytime they had any sleep issues. The problem is those medications are actually only FDA approved to be used short term, and they can actually have a lot of cognitive side effects as we age, particularly if you have something like Parkinson's disease. So actually over the past 5 years or so, there's been a movement away from that and a movement toward kind of behavioral interventions, which means non-medication interventions. Question is it effective? And the answer is yes. So you actually see treatment kind of efficacy in about 80% of people, which is a really high number when we talk about, treatment interventions. And it's designed to be short. So I would say most people need about 6 to 8 sessions to actually improve their sleep symptoms, sometimes shorter, sometimes longer. And I say it can always be used in conjunction, in lieu of, or as someone tapers off medication. So you can do these kind of behavioral interventions, even if you're already on some sleep medications. The good thing about this sleep intervention is that it really targets a lot of different factors that can contribute to poor sleep, some being physiological, again, feelings of anxiety, any kind of hypervigilance towards motor symptoms, things like that, behavioral things that we do, psychological factors, and environmental factors. So it really kind of targets all these different areas. Okay, the question is, are these sleep interventions effective in Parkinson's disease? And the initial studies say yes. So that's the really good news. There's probably not as many studies as there should be, but there have been a handful of studies saying that cognitive behavioral therapy for insomnia and these other sleep interventions can actually be really effective in reducing some of these symptoms, even if you do have Parkinson's disease. And in particular, a brief form of this treatment, meaning probably closer to 4 or 5 sessions, actually have been quite effective. Okay, I always like to say kind of what is normal sleep? And people always grow up hearing kind of 8 hours as the magic number. We hear that 8 hours because it's actually the average of a range. So I would say people actually need sleep somewhere between 6 to 10 hours. Some people are on the shorter side, and some people like me are unfortunately on the longer side. And so we talk about 8 as kind of the average, but it's not a magic number for everybody. As I mentioned before, your sleep need actually decreases over the lifespan. So let's say you grew up needing around 8 hours of sleep. But again, as you get into your 60s, 70s, 80s, on average, people's sleep need decreases about 45 minutes. So you actually may need closer to 7 hours. People always ask, well, what if I have a bad night of sleep here or there? Is that normal? And I say that is totally normal. So whenever you have a bad night of sleep, that's actually not too much to worry about. When you're having it several nights per week, over stretches of weeks and months, that might be a good indicator that we may want to intervene. People also ask, well, what is good sleep? And I say the goal is to fall asleep quickly. And if you get up in the middle of the night to use the restroom or something like that, the goal is to kind of go back to sleep quickly. And again, as we age, waking up to use the bathroom is totally normal. And so again, if you're waking frequently and kind of going to the bathroom and then getting back into bed, the goal is to fall asleep within 15 or 20 minutes or so. Okay, so I want to talk about medications here. So oftentimes people are on medications for poor sleep. For example, things like Advil PM, NyQuil, Unisom, things like that. I actually really strongly recommend against using those medications, particularly ones that, like the ones I listed here, because they're anticholinergic. And what that means is, as I mentioned before, with Parkinson's disease and as we age in general, your neurotransmitters, or kind of the things that send the signals in your brain, kind of get a little bit disrupted. And one of those neurotransmitters that gets disrupted is acetylcholine, which actually is really important for memory and really important for movement. When you take these over-the-counter medications, those medications kind of suck out even more acetylcholine. And so you can actually see really adverse symptoms from taking these medications, particularly in the domain of memory. So people might notice in the morning that they feel kind of like off or out of it. That can be from these anticholinergic side effects. What those medications have in them that does that is basically just a variant of Benadryl. So it's like Advil plus Benadryl for Advil PM, which causes some of these side effects. The thing that we usually recommend is actually melatonin. And so I have a different way that we give melatonin, which is actually different than what it says on the bottle. But melatonin is a natural sleep hormone that your body produces on its own. So on your own, your body produces melatonin right around 2 hours before your bedtime and kind of peaks in the brain. And so when you take melatonin, that's kind of from a gummy or a vitamin, you want to take it actually 3 hours before your desired bedtime. So on the bottle, it says take right before bed, but you actually want to take it 3 hours before your desired bedtime. And you want to do that because you want to kind of take it, have time to digest, and you want it to kind of supplement what your body's producing on its own. So if it's peaking at 2 hours, if you take it 3 hours in advance, it's going to peak, kind of lump on top what your body's already naturally doing. With melatonin, their dosages are kind of all over the place, but I say actually less is more. So you want to take somewhere between 3 to 5 milligrams. You don't need to actually take 10, 15, 20 milligrams. Not that anything bad is going to happen, but sometimes it can make you a little bit groggy or kind of have some weird dreams if you take a little bit too much. The remembering to take melatonin is the hard part. And so sometimes I encourage people to actually set an alarm on their phone 2 to 3 hours before your desired bedtime, so you remember to take the melatonin at the same time. So melatonin is not so much sorry, someone say something? Okay. Melatonin is not so much a sleep hormone as it is, again, one of these 24-hour clock things. So it's important to take at the same time. And again, you want to take a lower amount if you can. And I will say there's actually been a lot of research coming out that melatonin can actually be protective against COVID and other viral infections. So it's actually something that you may want to consider taking either way. Okay, these are the key principles that I always walk my patients through to say, like, this is how we get on the best track to good sleep. And as we talked about before, Parkinson's disease can disrupt your on-off switch with sleep as well as your 24-hour clock. So the really important thing, and I think is extra important when you have something like Parkinson's, is that it's important to keep the same bed and wake time 7 days a week. And so I say, you want this to be a wake up time, and I usually choose the wake up time first. That's going to work for you 7 days a week. So if you're working or you have other commitments, I say pick a time, even if it feels a little bit early, that is going to work for you 7 days a week, and keep a bedtime that, again, seems reasonable and will work for you 7 days a week. The trap that we often fall into is people maybe sleeping in on the weekends, or you have a bad night of sleep and you catch up on sleep. that actually causes a little bit of a roller coaster with your sleep hormones. And so, again, the more kind of consistent we can make it, can actually really help retrain some of your 24-hour clock. And again, your on off with a sleep switch to kind of be a little bit more mechanized and routine. As I said before, unfortunately, if you're having some sleep issues, I say you're not as fortunate to be able to kind of sleep in or go to bed earlier without some consequences happening with your sleep. But again, the idea is that once things are a little bit more routine and mechanized, you can fudge a little bit once everything is good. But at least while you're kind of trying to push your sleep in the correct direction, again, you want to be pretty consistent with your sleep and wake times. Okay. So the next thing we talk about is kind of extended periods of poor sleep can actually cause some anxiety, and which is counterproductive to poor sleep. So as I mentioned before, let's say you go to bed, you're feeling tired, you get into bed, and all of a sudden you can't sleep. And you're aware of the fact that you can't sleep. And then you're feeling anxious. And then you look at the clock and an hour has passed and 2 hours passed and you're tossing and turning. That can produce some anxiety, understandably so, which is counterproductive to sleep. So the goal is, what I say is, if you've been in bed for about 15 or 20 minutes or so, and you still haven't fallen asleep, I actually recommend to get out of bed and do a relaxing activity until you feel sleepy enough that you get back into bed. The reason why we do this is that if you have repeated attempts to be in bed and you're not falling asleep and it's causing anxiety, it can cause kind of a unconscious classical conditioning, with conditioning yourself to think of the bed or the bedtime process as anxiety inducing. So we are all actually very sensitive to environmental cues. An example I give is you're not hungry, but then you walk into the kitchen and all of a sudden you want a snack. The same thing can happen when you go to bed. So you weren't feeling anxious, but if you have a history of poor sleep, you can walk into the bedroom and all of a sudden you're starting to feel anxious. We want to minimize that. And the way you do that is, well, not spending any time in bed anxious. So I say this is not designed to keep you awake longer than you would be otherwise, but it's minimizing that kind of amount of time that you're spending in bed, tossing and turning and not sleeping anyway. Okay. People often ask, well, what do I do that's relaxing? I say it's up to you, but I'm pretty strict when I work with my patients in clinic, is that you want to do something that's not particularly entertaining and that isn't screen-based. The thing that we talk about with screens is that they all emit blue light. So your phone, your iPad, your TV, they all emit kind of a blue light spectrum, which actually suppresses those sleep hormones that we were just trying to get on track. And so I say, actually, probably want to stay away from screens in the middle of the night, though I know we often turn to television or a computer or something like that. What I usually recommend instead is something that's pretty kind of low arousal. So reading or listening to a podcast, or I have a lot of people do coloring books or fold laundry. I mean, something really not that exciting, because you want to get yourself to kind of start to feel sleepy again, and then you'll get back into bed. Okay. So the other thing is that, oftentimes, especially if you're having fatigue or kind of motor symptoms are acting up, we often spend time in bed when we're not meant to be sleeping. So sometimes people spend time in bed if they're resting or they want to watch TV or they're just on their phone. I actually caution against that because, again, we want to strengthen that relationship with bed equals sleep. And so if you have this process of spending time in bed and you're not sleeping, you're less likely to get your desired outcome, sleep, when you want to get it. So again, we kind of need to strengthen these kind of behavioral patterns because then you'll be much more likely to kind of get your desired outcome in the end. Okay. One thing I usually recommend is a buffer time between the day and going to bed. And so I give people a buffer time because it's often hard to kind of just go about your day, especially these days if you're watching the news, the stuff going on with family, and then just hopping into bed and expecting to go to sleep quickly. I usually give people kind of a buffer time, half an hour, hour or so, to kind of decompress before they get into bed. Again, that's another kind of environmental cue that we are transitioning now into bedtime, and you want to kind of start feeling sleepier in that kind of transition time. Again, I say that's a good time to kind of stop all electronics, get ready for bed, brush your teeth, put on pajamas, do any stretching, do anything like that. Again, it's a kind of decompression time between your kind of very busy day and bedtime. Okay, naps. So oftentimes people say, okay, I'm taking naps because I'm not sleeping that well at night. Is that going to affect my sleep? I say you really want to avoid long naps. And I'll tell you why, is that on off switch with our sleep. Well, the off switch is kind of a buildup of a hormone throughout the day. So these hormones are kind of building up in our brain throughout the day. And then when they hit their peak level, it's kind of the off switch so that we're able to go to sleep. When you take naps that are a little bit longer in the day, it's kind of decreasing that hormone. So you're not really at your peak level actually by the time you go to bed if you are taking longer naps. Things like naps lasting 15 to 20 minutes, I say are okay if you really need them. But really anything beyond that, you're kind of getting into dangerous territory if you are trying to get a good night's sleep kind of the following night. I say really anything over half an hour is probably getting, yeah, I know it feels short. But I say that's just around the point where it's kind of decreasing that hormone enough in your brain that you may see a little bit more fragmented sleep when you go to bed at night. And what I mean by
I
that is just like waking up a little bit more frequently. I know. What I say though is, these are kind of my strict rules if you're having bad sleep at night. But if your sleep looks good at night, there's no reason that you can't take longer naps if you feel like it's not affecting you. But I say for people that are noticing like it's hard to fall asleep, or they're waking up in the middle of the night too often, or they're waking up a little bit too early, like at 3, 4 a.m., and they can't go back to sleep. I say naps are a good thing to kind of bring down a little bit. Um, because your body's a little bit confused. It's trying to get you enough sleep over a 24-hour cycle. And when you kind of do it this way, as we shift things a little bit, it's kind of consolidating everything to like the nighttime, so that you're still getting the same amount of sleep, but just kind of in a more efficient period. But I hear you that it's really hard in the beginning because you feel like you're trying to catch up on sleep and you're tired. And I totally get it.
okay. Thanks.
Yeah. Okay. So we're going to talk about some environmental changes that I usually recommend for people. So as I talked about before, some new research saying caffeine can have a half-life up to 20 hours in people. Not that you can't have caffeine, but I really try to say limit caffeine to lunchtime and before. Anything after that can really have an effect on your sleep. Same thing with alcohol is that, one glass of wine with dinner is not going to be the end of the world, but oftentimes people use alcohol as a method to kind of help them fall asleep, but can actually cause a little bit more shallow, less deep sleep throughout the night. And of course, you want to try to limit tobacco if you smoke or if you vape because it's a stimulant. So you do not want to be doing that before bed if you can. So I had talked a little bit before about kind of blue light exposure, which is kind of what we all encounter. So again, you want to try to limit your blue light exposure from screens as much as you can in the evening. One way to do that is just not watch TV or be on your computer or screens or anything like that. But I think that's a little bit too harsh. And so if you want to kind of just continue about your life and not change anything, there are pairs of blue light blocking glasses that you can buy for about $15 or so on Amazon that can really help. Again, you want to just try to limit that blue light exposure because it can make it harder to go to sleep or stay asleep throughout the night. On the back end is that you want to maximize your natural daylight exposure during key periods and particularly during morning hours. For most people, I say that somewhere between 7 and 10 a.m. is that you really want to make sure you get maximum daylight exposure because again, that's going to help kind of entrain some of these 24-hour clocks that we're trying to retrain a little bit. I say this is hard with Parkinson's often. It feels like we're inside or we have a lot of artificial light or kind of all these things. But I say as much as you can, try to get that exposure. It doesn't mean that you have to go outside and stare at the sun. But, if you do exercise, I say it's preferable to exercise in the morning. If you're at home, open up all the shades, that kind of thing, so that you're getting as much natural daylight exposure during those key times if you can. Okay, we already talked about blue light exposure here. We already talked about exercise. One of the other things that you can do to actually train your 24-hour clock is to be eating meals at pretty consistent times. So I say your 24-hour clock, part of it is sleep, but part of it is your body temperature, which is why it's kind of hard to fall asleep in the summer because you're actually running too hot and you need to be on the cooler side when you go to sleep. Your meal times and other things. So I say having your meals at consistent times as much as you can is really good. And you don't want to be eating bigger meals too close to bedtime, is that oftentimes, again, you're kind of at increased risk of acid reflux or those kind of things waking you up, even if you aren't necessarily realizing that's what's happening in the middle of the night. So again, you want to try to limit meals if you can really close to bedtime or have a smaller snack if you can. Okay, these things are obvious, but you want to make sure your bedroom is cool, comfortable, and dark. All those things are very important. As I said, your core body temperature needs to be dipping right before bedtime to actually help you fall asleep. An example I give is if you've ever been in a hot tub and you get out and you feel really sleepy, it's not because the hot tub was super relaxing, but it's because your body temperature was really high while you were kind of cooking in the hot tub, and then it dropped really fast once you got out, which kind of induces sleepiness. So you can use a similar principle if you want. Anytime you take a shower, if you're taking a shower before bed and then move to a very cold bedroom, those are things you can try. But I just say it's a little bit easier to sleep in the wintertime because everything's cool versus the summertime because everyone's running a little bit hot, and that's counterproductive to sleep. Okay. So I want to leave a little more time here to kind of talk about personal questions or things that I can answer individually for people. But if you do have additional questions or want additional resources on kind of sleep disturbances in general, the Sleep Foundation actually has some good information, and particularly for those with sleep and Parkinson's disease. The American Parkinson's Disease Association has a good website on their kind of sleep management. One book I recommend to people is actually if you have insomnia symptoms. Oh, sorry, my dog is barking here in the background. If you have insomnia symptoms, there's a good book called Say Goodnight to Insomnia, which actually kind of walks you through a lot of the things that we talked about. If you want to kind of DIY this at home, or if you feel like you need somebody to kind of keep you accountable and kind of give you an increased level of care, we did talk about some things that I wouldn't recommend doing by yourself at home. Is if you want to see me in clinic, I'm always here to kind of see people that maybe need a little bit increased level of treatment with cognitive behavioral therapy for insomnia. And that is, I'm at the University Sleep and Pulmonary Associates, if that's something you guys are interested in. So I wanted to leave some time here to answer questions about, us covering all those things, but any particular questions you guys have about insomnia or restless legs or REM behavior disorder or anything like that. We're completely telehealth right now. And I think that treatment actually works really well via telehealth. So for the foreseeable future, we are all telehealth for now. I would recommend that's a good place to start. And what you can do is actually set an alarm on your phone. If you're like being intentional about your naps, is set an alarm for about 15 or 20 minutes or so. I know. But it's something to try. Well, it depends. Oftentimes when people are reporting a lot of daytime sleepiness, we always like to do a sleep study if we can, just to make sure that there's nothing like sleep apnea, which again can happen as we age, which can in particular cause a lot of daytime sleepiness. And that's because, again, at night, you're not getting very high quality sleep and you're kind of constantly waking up because your kind of airways obstructed. So that in particular can cause a lot of daytime sleepiness. So if you're having that, it may be wise to kind of get a sleep study to check it out and see if there's anything else like that going on. The goal is if you get up in the middle of the night, which is totally normal as we age, that you want to be able to go back to sleep within about 15 or 20 minutes or so. And if you can't go back to sleep or it's just not happening, is you don't want to spend a bunch of time kind of tossing and turning in bed. If it's not happening, I say get out of bed and you want to do like a low light, relaxing activity until you feel sleepy enough, at which point you'll get back into bed. Yeah. So, I mean, the goal is just to maybe, if you can, shorten that a little bit.
Okay.
Because I think, this isn't everybody's goal, but it often is. A lot of people's goal is to have more consolidated sleep at night and be sleeping less during the day. So if that's your goal, those are some strategies you can use. That's actually a cardinal symptom of sleep apnea. So you may want to get that checked. Is that when you wake up in the morning with a headache? That's usually one of the screening questions that we ask for sleep apnea. So maybe wise to get a sleep study. And they can do those normally in non-COVID times. You might go to the lab to get that sleep study, but they can actually do them ambulatory now, where they just kind of put the electrodes on you and they send you home. Good question. So there are a lot of options, as you noted, on the market for fixing sleep apnea. I say often because of insurance things and complications, we end up usually starting with a CPAP machine or a BiPAP, which is that one that you're talking about, is that machine. In the olden days, it was always kind of this big contraption, but there are newer things where it's just kind of pillows that can kind of sit at the base of your nostrils and aren't like as such a big thing. But, that doesn't work for everybody. But usually for insurance covering these things, I usually try to start with that one first. But if that doesn't work, there are other devices that people use. Sometimes people just can benefit from a dental device, which is like wearing some retainers with like a little bit of a bumper on it so that it's kind of making your airway open a little bit. Or I think you were talking about, there was this new kind of device that just got approved about a year or two ago that's called Inspire, which is they kind of like DBS, if you guys are familiar with that, in kind of using electrical stimulation, but it's kind of, they're looping the wire around kind of the nerve that will kind of almost flatten your tongue down. So just like DBS, you would kind of go to bed, turn the thing on and off as you want. And then when you turn it on, it kind of flattens your tongue so that, again, your airway is a little bit less obstructed. I say that's an option as well. And I usually say that, again, for kind of insurance purposes, they'll have you go through the rigmarole with these other devices first. But it is an option and actually can work really well for people with either PTSD or these other things or Parkinson's, where it's a little bit more effective with them for those reasons. That's a good question. I don't see why they couldn't, but I don't actually know of too many case studies where they're doing those two things together. But who I would recommend is, if you don't have a sleep physician that really specializes that Inspire device, is Dr. Lynn Keenan is really good with that device, and maybe a good person to ask those questions to. It depends kind of what's going on with their sleep. I'd say sometimes after the motor symptoms are a little bit more under control, sleep can be a little bit better, just if people are hyper vigilant to kind of the motor symptoms keeping them from going to sleep. But I've had other patients where they got the DBS and they're like, same old sleep and nothing really helped. So it really kind of depends person to person, I've noticed. But.
Okay.
Any other questions?
So some of the techniques that you discussed in proper sleep, could like getting a better night's sleep or getting on a schedule help with that REM sleep disorder, or is that specifically in the brain? Is that a hormone imbalance? What kind of addresses that?
Yeah, so REM behavior sleep disorder is a little bit different in that you're kind of having to override the system now that's happening, that your brain kind of when you were younger was always kind of keeping you in check. So the way that REM behavior disorder is usually treated with is medications, particularly benzodiazepines, that artificially don't let you go into REM sleep as much. there are environmental changes that we usually recommend with REM behavior sleep disorder. One is that, you want to stay away from things that actually can increase your chance of having emotionally charged dreams. So I have a lot of patients that are like, I just don't look at the news. I don't watch any scary movies. I don't do anything like that before bed because I know it's going to increase my chance of having kind of a more emotionally charged dream. And I'm going to move a little bit more. The other things is that like some people like remove all sharp objects from the room. If they're at the room with, at the top of the stairs, they move downstairs, things like that. Some people want to be super secure and have like locks or like jingle bells on their door to wake them up if they're opening the doors. So there are behavioral techniques that people use to kind of manage their environment. But in terms from like a intervention perspective, usually medication is the best from just keeping people from going into REM sleep to keep them a little bit safer. Good question. It's usually a class of medications called benzodiazepines. Only prescription, but actually melatonin's used in conjunction with those medications to decrease some of the symptoms of REM behavior disorder. So melatonin is something that you can use over the counter that can also help, but probably is not going to be as effective as some of these prescribed.
So let's say that they want a sleep study done, or they want the medication for the REM sleep disorder, or they want to see you. What path do they need to take in order to get these extra services?
So what I would recommend doing is that you kind of get in touch, and sometimes depending on your insurance, you may need a referral from your primary care. But I and my other colleagues, other sleep physicians, are at University Sleep and Pulmonary Associates. And we really treat all kinds of sleep disorders there. So sleep apnea, REM behavior disorder, restless legs, insomnia, circadian rhythm issues, really spans the gamut. But there's a really good set of clinicians there, and they're all UCSF faculty. So they're all very involved with kind of like, forward-thinking treatments and kind of stay up to date with the literature and have experience in working with patients with sleep disorders and kind of comorbid neurologic issues as well. And if you guys ever have any questions, just you think of off the bat or want to get in touch, you guys are always welcome to kind of reach out to me directly, and I'm happy to answer them. Okay. Well, if there's anything else, I appreciate you guys coming out today. And again, if you think of anything after the fact, you guys have my information. So happy to touch base.
Yeah, thank you so much for your time. That was very informative. So I appreciate that. I'm sure everyone else really appreciates it as well.
You're very welcome. Take care, guys.